I would be delving upon a topic which is a recent addition to the armamentarium in the treatment of carcinoma cervix. And I would run through the various new things which are happening in cervix and how they are being organized into the treatment paradigms when we go about treating advanced metastatic carcinoma cervix. So this is what we had. The current outlook of patients with persistent, recurrent, or metastatic cervical cancer is poor. There is a dismal 5-year survival rate of 17%. So in 2014, the vascular endothelial growth factor inhibitor, that is bevacizumab, this was a monoclonal antibody. This was approved in the combination with standard of care chemotherapy as the first line. So prior to this, you just had combination chemotherapy, and after that, in 2014, this came as a value addition where the chemotherapy would just hit the cancer cells, the VEGF would cut the blood supply, and that would lead to an addition in the survival. But again, based on this, there was an improvement in survival only of about 2 to 3 months, that is 16.8 months versus 13.3 months. And nearly all the patients relapsed after the first line therapy. And then subsequently, the available second line and later treatment options were poor, and they were characterized by low response rates. Risk factors depended upon the advanced or the metastatic disease, the large size tumors, the brain metastasis at presentation, poor adherence to follow-up for managing abnormal cytologies. So these were the cases which were there when these patients were there. So this would be the schema of my talk. What I will not discuss is the normal chemotherapeutic drugs. What I will discuss is how we took off from bevacizumab to immunotherapy to dual immunotherapy and later on to cancer vaccines. So coming to bevacizumab, as I told you, this is a vascular endothelial growth factor inhibitor monoclonal antibody. This was incorporated into this trial. This was GOG 240 trial in these patients who had advanced cervical cancer with no prior chemotherapy or recurrence. So you had basically two arms here. That is chemotherapy alone, that was paclitaxel plus cisplatin or paclitaxel plus topotecan plus minus bevacizumab. So this was a phase 3 study in a 1:1:1:1 randomization with primary endpoints of overall survival and secondary endpoints of progression-free survival. So when you had that, you saw that in the intent to treat population, the difference was about 3 months. But when you translated into those patients who didn't have any radiation prior, it jumped up from 16 months to 24 months. So this was definitely a value addition in which patients who were given combination chemotherapy, along with that, when the VEGF was added, that led to a jump of almost about 4 to 5 months across the board. Now, this was the starting which I had alluded to you in the beginning. Now we come to the new era, that is the addition of immunotherapy in carcinoma cervix. So if you talk of the rationale for immunotherapy, there is a direct correlation between immunosuppression and invasion. And that is concomitant with a cascade of cytokines, release of interleukin-6, PD-L1 upregulation, and also hypoxia and tumor growth factor beta and ROS. So when this occurs, there is a suggestion that there is a role of immuno-oncology drugs in carcinoma cervix. So if you see for the first line, the trial which was there, that was the Keynote 826, in which the design was chemotherapy plus bevacizumab only, or chemotherapy plus bevacizumab plus pembrolizumab, which is immuno-oncology drug. This is a PD-L1 inhibitor. The dual primary endpoints were the overall survival and progression-free survival, and the secondary endpoints were the quality of life indices and the overall response rates. So it was a 2-arm study, and it was continued till progression or unacceptable toxicity. And these were the patient characteristics which were very well matched. Suffice to say that you see in those patients who had a PD-L1 CPS score more than equal to 1 and higher, these were the patients who benefited with addition of immuno-oncology drugs to a combination of chemotherapy plus bevacizumab. So you started with the chemotherapy drugs, single agent chemotherapy drugs. Then you went to a combination chemotherapy drugs. Then you went to combination chemotherapy drugs plus a VEGF, that is bevacizumab. And now you have 4-drug combination, which gives you a defined benefit, whether it is the progression-free survival or it was the overall survival. But this was in those patients who had a PDL1 of CPS or more than equal to 1. And you saw that if you see in this forest plot, the patients who had a combination with the immuno-oncology drug, they did better than those patients who did not have. So this was the immuno-oncology drugs in first line. But patients who have already taken chemotherapy or chemotherapy plus bevacizumab, in the second line also, this was seen in Keynote 158 trial, in which this drug, pembrolizumab, was given as a single agent therapy. And this was continued till unacceptable toxicity or if the patient progressed. And the primary endpoint in this was the overall response rates. So here also you see that patients who have got PDL1 of more than 1%, there was a defined improvement in the progression-free survival and overall survival, and 50% of the responders had ongoing benefit from treatment beyond 24 months at the date of cutoff. The third drug which is there, that is semiplimab. This was again pitted against the standard, which was chemotherapy, that was either pemetrexed, topotecan, irinotecan, gemcitabine, or vilobelimab. And this was given till death or till study completion. And the treatment discontinuation was when the patient did not tolerate it or the patient progressed. And the primary endpoint was overall survival. And here again, you see that patients with squamous cell carcinoma, there was a definite improvement in the overall survival as against those patients who were given chemotherapy, which is in the red. So this trial, it was stopped early due to positive results, and the median overall survival of 12 months versus 8.5 months was there. This was actually the physician's choice of chemotherapy. So even in those patients who had recurrent disease, you had a survival benefit of 4 months, which translated into a good quality of life for 1 year. Now, you've seen patients who are getting chemotherapy, you've seen patients who are getting chemotherapy plus targeted therapy. Then I showed you a trial in which all 4 were there, that is chemotherapy, single agent or double agent, plus targeted therapy, plus immunotherapy. Now you have patients who are given dual chemotherapy, that is a combination of PD-L1 and anti-CTLA-4, and this was these 2 drugs, that is balstilimab and zalifrelimab. So you have tongue twisters here. So balstilimab is an anti-PD-1 and zalifrelimab is an anti-CTLA-4. This was a phase 2 study in advanced recurrent metastatic cervical cancer patients. And these were treated up to a period of 2 years. And imaging was done every 6 weeks through the 2 years. And the primary endpoints were overall response rates. And the secondary endpoint was the progression-free survival and the overall survival. So if you see this waterfall, you see that patients who are PDL1 positive, they are the ones who are having the best responses in this. And despite the fact that most of the patients were recurrent or they had disease which had come back after the primary treatment, there were complete responses and partial responses in about 32 cases, which was a very, very welcome sign. So this is the largest study till date, which is blockage of PDL1 plus a CTLA-4 checkpoint blockade. And this showed important improvement in the complete responses and the partial responses, giving a good overall survival rate. So the next is the antibody drug conjugates. Here, this is a drug which is now upcoming. This is tisotumab vedotin. How does it work? This is having a direct cytotoxicity reaction. It has a bystander killing. It has antigen-dependent cellular cytotoxicity, and it also can cause immunogenic cell death. So this is basically an antibody drug conjugated, which is directed to the covalently linked microtubule disrupting the protease cleavageable linkers in the body. And here you see that this is the basic action, that is ADCC, antigen-dependent cellular cytotoxicity, antigen-dependent cellular phagocytosis, or the immunogenic cell death. So this was seen in the trial. This is the INNOVA trial. This was a multi-center phase 2 single-arm study in which this drug was given to those patients who had taken already 2 sets of chemotherapy, and this was continued till progression of disease or unacceptable toxicity. Here again, you found that we had a lot of patients who had responses, and there were confirmed overall response rates of about 24%, despite the fact that these patients had were heavily pretreated earlier. And these were the adverse events of interest, and ocular adverse events were the most common, and there were generally of grade 1 or grade 2 and easily resolved. There was another trial, which was the CLAP trial, in which another drug, that is camrelizumab, was given at 200 milligrams every 2 weeks with apatinib, which is a TKI, and continued till 4 cycles up to a maximum of 24 months. And this total of 57.8% of patients had previously received 2 or more lines. So initially we used to talk of only 1 or 2 lines, because after that patients didn't have good performance status in general condition. But now you had patients who were getting 2nd line, 3rd line, 4th line because of these new drugs, which could be very nicely tolerated. And at a median follow-up of almost 1 year, you found that there was an overall response rate of 55 or rather 60%, and median duration of response was not reached. So the last is the cancer vaccine. So we are going up and up and up and up, from targeted therapy to immunotherapy to dual combination of immunotherapy to cancer vaccines and to antigen-dependent cellular cytotoxic drugs. So here we know that there is a association of HPV, that is human papillomavirus, with the cervical squamous cell carcinoma. So that makes the HPV-related proteins attractive targets for vaccine-based therapy. And you have a live Listeria monocytogenesis encoding E7 oncoprotein, which is tagged to the vector vaccine, that is this number. And the initial results show a 12-month overall survival of about 40% in these patients. So these are undergoing trials. Suffice to say that it deserves a mention because they are having combination benefits. Another one is there, which was combined with the cisplatin, that is a chemotherapy drug in advanced cervical carcinoma, and that again is showing 35% response rates. You have a combination with the immuno-oncology drugs. These vaccines are combined with nivolumab, and in phase 2 studies are showing another response, overall response of about 33%. And these are the trials which are going on. We talk of precision medicine, we talk of all these trials, and probably in times to come, we'll have a kind of a tailor-made therapy for these patients, even in the advanced metastatic stages. So this is the mother slide, in which you have all these stages which has been discussed threadbare in the past lectures. You have cervical dysplasia, then early disease, locally advanced disease, and this is where we come as medical oncologists when you come for the metastatic disease, or probably the loco-regional advanced disease where you give chemoradiotherapy. So if you have a stage 4 disease here, I think we should focus on the last. Then the first line of treatment is platinum-based chemotherapy combination. So if you have the patient here, if you can see the arrow, you give a platinum-based combination, preferably cisplatin. If the patient has deranged KFTs, or if the glomerular filtration rate, that is GFR, is low, then these patients can be given carboplatin. Along with that, the drug of choice is paclitaxel. And then, as I showed you in the trial, the GOG trial, when you combine these 2 drugs, that is paclitaxel and carboplatin, with bevacizumab, you have an incremental benefit of about 3 months. But if these patients are the ones which have not been given chemoradiotherapy prior, there is an incremental benefit of about 10 to 11 months. And now as I showed you in the study, along with a combination of cisplatin and paclitaxel and bevacizumab, you can add pembrolizumab, which I showed you in the keynote study, and in those patients who have a PDL1 of CPS more than 1. So when you give these 4 drugs, there is a further increment in the survival in patients of carcinoma cervix. Now, when you jump to the second line, if you have not given these patients immuno-oncology drugs, then I showed you one trial in which pembrolizumab can be given as a single agent, and these patients again have a survival benefit. If these patients have a microsatellite instability or MSI is high, these patients again can be given immuno-oncology drugs. If you have just given chemotherapy drugs, that is just paclitaxel and carboplatin in the first line, in the second line, you can give again bevacizumab, which is a VEGF inhibitor as a single agent or in combination. And subsequently, you can give tisotumab vedotin as a second line drug in those patients if the drug is available in Bangladesh, or you can give single agent chemotherapy if there are cost constraints. Sometimes we give metronomic chemotherapy also. There are a few papers from India where capecitabine can be given as a single agent drug in those patients who don't have a great general condition and performance status, or there are severe cost constraints. Even in those conditions, these people, they tend to respond to a certain extent of time. So cervical cancer, stage 4, which used to be dismal, now you are spoiled for choices. You can give chemotherapy, you can give single agent chemotherapy. Single agent chemotherapy can be anything like taxanes, paclitaxel, or docetaxel with cisplatin, with carboplatin, or it can be irinotecan, or it can be topotecan, or it can be gemcitabine. Then with a combination, you can give paclitaxel and platinums. Then if you can go further, then you can give paclitaxel plus platinum plus bevacizumab, which is a VEGF inhibitor. Or if you want to go still further, you can add immuno-oncology drugs like pembrolizumab. So this is all in first line. So you're spoiled for choices, provided the budget allows and provided the drugs are available freely there. If you go to the second line, if you have not given a VEGF blocker, that is bevacizumab, you can add that. If you have not given immuno-oncology drug, and if the general condition of the patient is not that great, you can give a single IO drug, or you can give tisotumab vedotin, or you can give any one of the chemotherapy drugs as a single agent if the general condition does not coincide. So these agents can be, as I told you, it can be ifosfamide, can be gemcitabine, can be topotecan, can be irinotecan, and so on and so forth. If you want to give a metronomic chemotherapy, small dose, continuous, like a 5-FU infusion, then you can give capecitabine in these patients. So I think I'll just stop here. I thank you for your patient hearing.